Yeah, definitely. I mean, there are things that have been useful from social media. Like, if you look at, there's a lot of websites, like online. I mean, I'm talking about the internet, from big institutions like the Mayo Clinic or Cleveland Clinic and so on, and in the UK as well, that explains everything to the patient. And our ENT UK has so much stuff. So
Yeah.
these are really good for patients to get information. But for facial plastic and cosmetic surgery, it's completely opposite sometimes.
So, thank you very much, Hesham. It's lovely to see you.
You too.
So, Professor Saleh is one of the great leading lights of ENT surgery and a personal mentor and friend. So, thank you so much for agreeing to this discussion today. Really lovely to see you.
Thank you for inviting me.
Yeah, tell me a little bit, perhaps, if we start, introduce who you are for those who don't know you. Obviously, within the field of ENT, there's no one who doesn't know you. But outside of that, who you are, where you work now, and what you do.
So I'm a consultant ENT, but the specialization is basically rhinology, which is sinus, and facial plastic, but that's mainly septorrhino and nasal reconstruction. I work in the Imperial College. It's mainly Charing Cross Hospital. So I'm really based in Charing Cross, but I do some clinics in the Royal Brompton. And because the Imperial also covered St. Mary's and Hammersmith, we sort of oversee the these parts of of the Imperial as well. But really, all my sessions are Charing Cross and Brompton. So I would do sinus, complex sinus surgery, skull base, and septal rhinoplasty. I also obviously do private practice. And a few years ago, I was given the title of Professor of Practice in Rhinology in the Imperial.
Which is very prestigious.
Which is nice. Yes,
Yeah.
it's takes I think it takes a lot of experience and a lot of things that you have to have done before you get it, and it's a long process of application and so on, which is quite nice because it helps me for teaching as well, and for representing the Imperial internationally more. It's good. It's good for the Imperial as well as good for me, of course.
Yeah. I mean, you're an incredibly passionate teacher, aren't you? And I think you're very well known within surgery in general and ENT, which is ear, nose, and throat surgery in particular, as an incredibly dedicated, passionate teacher of the practice. And and obviously for those who don't know, is Imperial is probably one of the biggest trusts within the UK, certainly within London. It looks after a huge patch in northwest of London, and under it fall a number of hospitals, which obviously you will cover, the Royal Brompton, which is a specialist heart and lung centre, being one of them. Tell me a little bit around how you journeyed into ENT. Where does that sort of because you're incredibly passionate about it, right? And you love it. You really, really do love it. You teach it, you research it, you operate on it, etc. How did you find yourself in ENT? How did that start, and how did the medical journey start? And we might have to go back to the young Hesham and
We have to, yeah, we have to. Yes. Yeah, so that's an interesting story, So I actually did like ENT. So when I was a medical student, I really liked ENT. You do like a short period, like few weeks of ENT or every specialty anyway. So I thought, I like that specialty, but I didn't decided anything. You're just a young student. Then I came to, so I graduated in Egypt. My parents had moved to England already anyway. So I moved, I followed my brother. You have to do the exam, the PLAB and all that, which was quite tough. So be allowed to work in the UK. And I hadn't decided what I'm going to do yet. I thought I was just going to be a surgeon, but I actually was looking at cardiac surgery.
Okay.
Why? Because this professor, Magdi Yakubu, was very famous then, and he was amazing, Egyptian as well. And I want to be like him.
It's very inspirational.
It was very inspirational, and I wanted to be a surgeon anyway. So to do any surgical specialty, you have to start with general surgery, and then you have to do accident and emergency. It was like this at the time, completely different system. And then you go for the specialty you want, and then you can proceed until you do your exams, and then you apply for registrar and so on. So I applied for general surgery. That was my first job in the UK. I did it. It was in a remote place. And then I got a casualty job, and I was doing my exams and so on. And in the meantime, I was talking to various people about cardiac surgery and so on to see what I'm going to do. And the cardiac surgeries that I saw were a bit too much for me, actually. But also they worked too much. One of them said to me, yeah, you'll be 50 and you'll be on call and you go to the hospital at 3 a.m. That's just normal all the time. I said, I couldn't imagine myself being 50 and just not sleeping and so on. Then I was in the ward, keep thinking, oh, do I really want to do cardiac surgery? And then there was this gentleman who kept coming to the ward. I was doing general surgery, and everybody's talking to him is very smiley and very nice and relaxed. And he goes away, and people just really like him. Then I said, "Who is that?" He said, "He's an ENT consultant." I said, "Oh, he's very nice. They all like that." I said, "Really? Wow." I said, "Yeah, ENT. They all like this." I said, "Oh, I used to like ENT when I was young. You know, can I see him?" So I went to see him. He said, "Oh, come and watch this." So I thought, wow, there's a lot of surgery and interesting stuff and the variety. I like that. I want to do that. So that was it. So I decided then, no cardiac surgery. It's ENT.
TNT. So you would have been the more sort of what was in old money called senior house officer. You'd
I
have
was
been
SHO, senior house officer in general surgery then. Yeah.
now
Which you
they're
have,
known as core trainees. Yeah. So
yeah, you had
very
to do as what you called core trainee. Now it wasn't, so that time there was no structure. So you basically apply for jobs every 6 months. So you apply for general surgery and then you apply for accident emergency. And then you're supposed to apply for a specialty that you don't have to do, but related to what you have to do in the future. So for example, if you want to do ENT, you would probably do neurosurgery or plastics,
yeah.
but you didn't have to do that. So I did general surgery, then accident emergency, then ENT. So I
In the
started
same
my,
place where the guy.
no, different places. No, because I'm not a local graduate, it wasn't that simple. So basically, people told me, you really want to do ENT in the UK, forget it. It's not going to happen. It's impossible
Because it was hard to get into.
because it's very hard to get into. I said, we'll see, you know. And so I apply. I worked in Yorkshire for the for the general surgery job. And that was after 27th application, I had one interview. So that was my first job. So I got that job. And after that job, I applied to casualty for a lot of jobs. I can't remember how many. And I got interviews in Middlesbrough and Wales. That was it. Not even Yorkshire. So I went to Middlesbrough. Actually, I was offered the job, and the following day, I was offered the job also in Wales, in South Wales, Abergavenny. And then people said to me, "Don't go to Middlesbrough. The job is busy and there's lots of problems, and you want to study for your exam." So sadly, I did apologize, which I do regret to the consultant then. Yeah, but he had another person anyway. So I did the job there. I passed my exam while I was there and all that, which was very useful.
This
And
is
then I got it.
this is the primaries, the FRCS.
Primary FRCS. The exams then was completely different from now. Primary
Very, very
FRCS.
difficult to pass. I think
Yeah,
it's
you
less
have to read a
than
lot of
20%.
anatomy, a lot of
Yeah.
physiology, exactly, a lot of biochemistry. So did the exam, and I then got the ENT job in Boston, Lincolnshire, which people even didn't know. My consultants were great there, actually, very. And they told me, you really to proceed, you have to be in teaching hospitals. And one of the registrars said to me, "Do you have any papers?" I said, "What papers?" They said, I have to do research. I said, "Okay, why didn't anybody tell me that?"
Yeah. It's
So I
funny,
did
isn't
that.
it? You kind of find these things as you go along, and
Yeah,
it's not nobody
was
tells you
nobody
this is what you
advising me
should be
anything.
doing. There's no mentorship. Yeah.
Yeah. By then, yeah, so I wrote a paper immediately. I did a case report, and then I got a job in Nottingham. While I was in Nottingham,
An
uh,
ENT job, this one now.
and ENT now, yeah,
Yeah.
so SHO. Uh, I went. I wanted advice from a senior. Then I thought maybe I should get an advice from some senior ENT. So then Mr. Omar Shaheen, who was really well-known consultant guys, he was a friend of my dad. So I went to see him, and he gave me a lot of advice. He said, "You continue working hard and so on." Yeah, it was very useful advice. And yeah, from then onwards, it was still actually not straightforward to get the registrar jobs because of my status as foreign graduate, but also the visa status because they hadn't actually, even though my family was living here, it was not that simple to get the permanent residency yet. So I couldn't apply straight away for numbers. So I had to
Yeah.
do locums. So I did locum registrars, Liverpool, and then uh, Plymouth and Turkey. And then I got my number training, which was in Scotland. So I traveled a lot. When I give a
Wow.
lecture, yeah, when I give the lecture on my the presidential address, they call it in the RSM 10 years ago. So I put a map to see where I moved from, tick, 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 like that. So I got my numbers. Dundee was amazing job, brilliant training. And I think from then I really liked the way they trained us, and I wanted
Yeah.
to do the same because you felt the consultants were really just dedicated to look after us. They had the time. It was a different perspective from what we have in London. You're busy. You're running around, do a lot more things here. But they, we had an amazing, like, built department. It was designed to be contained in one unit, so everything is there. We had a lab, we had like area for dissections for the trainees, everything. And I had a really nice training for 2 years. But then my wife wanted to move to London to work at the BBC. And then we moved. I applied here and just moved to London. And again, met amazing people. And I was trained by the top rhinologist. By then, I've decided I'm just going to be a rhinologist. Because when I actually was in Dundee, I worked with Paul White, who was amazing, rhinologist. I thought, this is my specialty. So that was after doing about 2 years of ENT as a reg. I liked that, and I thought, this is it. So I worked then in the what I call the North Thames rotation anyway, and I ended up working with Valley Land, then Ian Mackay, or where my
You
dream,
are, you are,
my
you are
dream to
literally,
work with.
yeah,
Yeah,
yeah. I mean, Ian Mackay and Valerie Land are the other, probably from the last sort of 50 years are the leading lights
yeah,
of rhinology. I mean, they are sort of world
yeah,
famous and have been awarded that. So just to sort of dive into that a little deeper. So it's really interesting because as you were talking, it reminds me of or prompts me to think how different it is for the trainees today.
yeah.
Although you moved over the lot quite a few times and all over the UK, you had a lot of agency and decision over what you did with your life. And one of
Yeah.
the issues for trainees today is that that choice is much more restricted. Everything is
Very limited.
formalized into, yeah, correct. Everything is formalized and squeezed
Yeah,
into set pathways which they can't kind of almost get out of.
yeah,
And we learn at different rates, don't we? And we decide what we want to do at different rates. And
yeah,
so despite the fact that it was difficult, it sounds like because you were so driven, both once you've decided ENT is your chosen field and then to subspecialize in nasal surgery rhinology, the next step, you could use that agency to go to places where you felt you had the best training, right?
yeah. So exactly, you're right. Yeah, exactly. Yeah, you had a bit more freedom. I mean, much more freedom to move around and choose where you want to go, which in my situation, yeah, it gave me advantage because I moved around. We worked with a lot of top people across the country anyway, but it took longer. That's one thing. So you would say the new system was created to try to make it a bit shorter and to make it organized so it's easier. But then it does restrict your choices. So you could go to an area that doesn't have the subspecialty in the level that you want, for example. So it definitely is. So there have to be solutions for this, which is the creation of fellowships, because people, if they do a training somewhere and they still want to do more than the fellowships. And this is what we're doing now. And I think that's why the number of fellowships increased now.
Mm.
I created the first fellowship in the UK, which is 2003. There was no fellowship in
Rhinology.
rhinology.
Yeah.
Yeah, there
Yeah.
was no
Imperial
fellowship.
College Fellowship. Yeah. Yeah.
And I fought for the hospital to pay for it, but they wanted. So I had it for free. So, but the fellows came anyway, and they got money from wherever until at some stage it was a bit too much when my Australian fellow had a baby and it was just too much. I said, okay, I'm not having any more fellows. So then the hospital said, okay, we're going to pay them a salary.
Because actually they contribute a lot. They're very, very senior in
They
that.
senior, yeah,
Very, very
yeah,
often they've done 20 years as a
yeah,
doctor. So
yeah,
yeah, it's a bit of a quirk, isn't it, of medicine? I mean, until recently they used to be called junior doctors and now they're resident doctors. But you
yeah,
can be in your 40s, having done 20 years as a
yeah,
doctor, very, very senior in your training, and you're still called a resident doctor just because you haven't made that jump to being a
yeah,
consultant, which
because you
seems
haven't.
crazy.
Yeah, because yeah, it's interesting, isn't it? They changed that name because now they're probably getting older because they spend a long time. But yeah, yeah, and doctors they have families, uh, but they still moving around. So my current fellow, he has 2 children. He had to move from the north to come down to London, and his family had to follow him. So
Yeah.
still unsettling. The system in the UK, the training is great because people finish a training are really experienced, but it is long and it does affect your family. If you look
Yeah.
at the system in Australia or the United States, it's quite intense, it's short.
But
They
for a
finish
shorter
in
period
young
of
age.
time.
Yeah, they finish in young age. They have good enough experience as well.
Yeah.
I don't know how we can make our system like theirs. It's because it's all based in their, like, for example, in Australia, the public system, how it works. Here, NHS is structured that way that the trainees are workers as well.
Yes.
They're not just there to actually learn, they're providing service, aren't they? So
And that
that's why.
sometimes is a real problem because there is service provision on one side, and the majority of
Yeah,
what the NHS provides is actually provided by training grades, which I
yeah,
think is also bad. It
yeah,
doesn't quite capture the seniority, the experience, and
yeah,
the level of training of this group of people,
exactly.
doctors. But then the second thing is training, and that is for someone which will come to later on as well. But it's probably just good to highlight now for someone like yourself. When you say that one of the best units you worked in, I think, did you say was Newcastle, Nottingham, which
Yeah,
was
Dundee, Dundee.
sorry, Dundee.
Yeah,
That they had, you had the wet lab there, you had, ability to drill temporal bones, which is obviously
yeah,
for surgery of the ear. And you had really dedicated time with your trainers, with the consultants. And one
yeah,
of the things that we hear a lot from consultants now, particularly senior ones like yourself, is you just don't have as much time to teach as you would like.
yeah.
And
That's
that's
true.
that's not
Yeah,
good. It's, we
yeah,
don't have that space to teach and pass on that knowledge as well as we should.
yeah. That's yeah. Sadly, it's the case, and it's reflected on the system itself, how it's run, and so on. Uh, and you go more south, you go, you find the consultants are busy because they have to do more private practice and so on as well. So that's
Mm-hmm.
one of the advantages in Dundee, that they didn't have to do that as well. So they
Yeah.
had the time. But the way the department was structured, it was modeled on a Canadian department, because the head of the department, then Robert Blair, he was a consultant in Canada for 9, 10 years. And he modeled the system to us in Dundee. Because obviously the residents, they call them residents anyway in the United States and Canada, they're there just to learn. So they basically students. They do the work as well, but they're students, so they supervise all the time. So that's
Mhm.
how they did it. So I'm actually doing something in here, not exactly the same, but I run my clinic like this. I convinced the manager that I lost. So I stand in the middle, and all the residents are in the rooms calling the patients. Every patient, they talk to the patient, get the history, then I go and join them, and I discuss the patient with them, and examine the patient with them, and move. So I can see all the patients. And I think this is much better teaching way, and much better for the patient, of course, because the consultant who is there to consult, not just to sit in a room, seeing
Yeah.
a certain number of patients, not seeing the others. So this
Yes.
is what I'm
It's
trying
the
to.
old style consultant model, isn't it? That's what
Yeah.
consultants to
And
be,
it
really.
works. It
Yeah.
works. But somehow, obviously, the NHS management has got settled that way that a consultant is sitting in the room
Yeah.
and just calls the patient. But now, with all these computer things that you have to, like actually we've done an audit, how much time you're spending putting information in the computer and how much time you're spending with the patient. It turned out that you putting things in
Spend
the
more time with
computer
a computer than a
more
patient,
time.
right?
Yeah. So, but if you're a consultant, use your clinical skill that you've accumulated for years and years and years to
Yeah.
consult, and let these things done by somebody else. So this is what I'm
Yeah.
doing.
That's a
And
very
I hope
interesting
that everybody
point.
else.
They're trying to make it like as if a consultant time is the same as any other, as if doctor
Yeah.
was changeable, then they're really
Yeah.
not. No, you're right. I'm going to take you back a little bit and ask you about what it was like, as somebody who wasn't a UK graduate, how was that for you? And was that something that you felt you needed to adjust anything for? Was it, because it was hard for everyone, right? To get into
Yeah.
ENT, to get it was
Yeah.
difficult all round. But how did you find it? How was that transition? I know your parents had moved here already.
Yeah.
Uh, and in some ways, do you reflect on some of the things that are going on now, seeing that I think it's even over 40% of the core trainee level, the SHO grade, is at the moment being provided for by non-UK graduates. So one of the challenges, because I think you were, whilst
Yeah.
you weren't the only one, but there wasn't that many UK graduates at that point doing what you're doing. Whereas now a huge amount of service delivery, basically seeing and treating patients, is delivered by non-UK graduates, which actually is one of the current issues that the BMA is talking about. Tell me how was it for you then, and what do you think has gone on since that
It's
time?
yeah. It's maybe it was a bit different. It's interesting then, because in the beginning, I'll just give you an example of something. When I worked in the non-teaching hospitals, there were some foreign graduates.
Yeah,
Not as much as now. We wouldn't say 40%, maybe 10%.
yeah,
When I worked in the teaching hospital, it was only me in the department from any level. I was the only SHO, foreign graduate, nobody else, when I got appointed in Nottingham. And actually, I remembered because my friend Mike Saunders sent me, look, I found the rota on call in July 1992.
Oh, wow.
Yeah, and he sent it to me just like a couple of weeks ago. So what happened in the foreign graduate found jobs in the district hospitals. So they didn't found the training jobs as much. This is what happened, unless they proved themselves with publications, exams, and everything else. So that was the hard thing then. I think now is a lot of the UK graduates are leaving, seem to be. So they're
Yes.
going to Australia and so on. So that's why there's more open for foreign graduates to come in as well.
Yeah.
So obviously, when you studied somewhere else, if you go back to your question again, completely different system. But actually, the PLAB did help me to understand the system, studying for the PLAB, because then you know exactly what's it like here, and just do like attachment in hospitals and so on. You're never actually the same as a local graduate, knowledge-wise, and because they've been exposed to everything. So I'm not saying it's completely justified not to give the non-local graduate jobs, because it was a bit an extreme thing then. So don't get shortlisted if you're non-local graduate to most jobs anyway at that time.
Which
Even
is
you have a
also
leave.
not right, right?
In
I mean,
my time. Yeah, of course. I mean, there was a paper published, very famous. I was talking about this yesterday with my fellow, Sam Everington, I think, and they did the fake CVs and like with different names, like Indian names and like Western names, and the percent of the difference shortlisting was staggering.
Yeah.
So things like this used to happen in my time anyway, and it happened to me across all the time until I got the consultant job, and that's it. So it was like that, you know.
Yeah.
I don't know what's it like now, but you know, like now, obviously, so many procedures to prevent that, which is de-anonymize that, there's no names and so on. Yeah, which is great. But I think things have changed a lot. And I think the system will always depend on non-local graduates because you never have enough graduates from the UK medical schools anyway. And imagine now is a huge immigration from them. Like I see the medical students. I'm responsible for something we call the specialist placement in ENT, which I have a student for a month.
These are medical students, right?
Yeah,
From
medical
Imperial.
students. They come, they spend a month. The ones who are really interested in ENT. So I've created that a long time ago with the medical school because when I realized that students, they only come for a week was not enough. So if anybody's interested, so I have about 4 or 5 or 6 maybe students a year. So every time I ask them, what do you want to do? I'm going to go to Australia or something like that, or I'm going to go to US. So many of them say that now. Yeah, they don't want to stay. So sadly, the system has done something to these young doctors to feel that there's just not hopeful for them to stay here. It's not like some good perspective, so they want to leave. So something is wrong is happening. It needs to be fixed. Yeah.
I think you're right, and this sort of so the tragedy that sort of is going to befall us, I think, will be more obvious in about 5 years.
Yeah.
When actually these students that you're hearing with the desire to move actually become doctors and then do move if they don't see that their lot changes. So now I'm going to take you back to when you decided to do ENT. What was it about the rhinology bit? And obviously you and I know what falls under rhinology, which is just noses. But for the man on the street, what is it? What's rhinology? What because people see the end of your nose and you think, well, it's not. There can't be that much to do in there.
Yeah.
So what is rhinology? And
many
things.
That.
Yeah.
Yeah, I'll tell you why. Actually, that I could really think of when I actually thought I'd like that. So rhinology, obviously, anything related to the nose, yeah. But it starts with from inside and outside. So I gave my lecture, I call it that nose inside and out once, which is my RSM lecture, because then talked about the inside. So the inside is the sinuses and
So we
allergies.
need to get that lecture up on the UDoc as well, because that would be a very interesting one.
Yeah, this lecture, I do RSM have it as a saved lecture. I have it as well as video.
Yeah.
So, and then, so basically, so rhinology obviously dealing with sinusitis, which is so common, yeah, and allergy, which is really common.
Sinuses, yeah.
Yeah, sinuses, sinusitis, which like 5% of, at this point we're sitting here, 5% of UK population has sinusitis. It's a lot, millions, yeah. So it's very common, and also allergies. but then it extends something that we worked on later on, which extended sinus, which you deal with the brain because it's close and you can actually deal with that through the nose anyway. So that's one aspect of it. But then the outside, which is the shape of the nose, but also the septum, which is what you can block your breathing. It's broken or deviated or something. So then you can do a cosmetic part, which you change the shape of the nose. So all this covers rhinology in a way. And the bit I liked in the beginning was the sinus surgery, because what happened in the late 80s, early 90s, there was a revolution on sinus surgery. So it was basically coming from Austria, interestingly, that they studied how things work, the physiology of the sinuses, and realized the way they did it at that time was wrong. You have to use cameras and endoscopes, and you target the areas to open, which are where the drainage comes from naturally, not just make holes everywhere that they did in the past. So really changed it. And the leaders of this were Ian Mackay, who was the first one to do this, and Valerie, who was his student later on, Valerie Lund, who became professor of rhinology as well. And I saw
Now
this
Dame
coming.
Valerie Lund.
Yeah, Dame Valerie. So I was working in Nottingham as a young senior house officer, and the new consultant just started 6 months ago called Nick Jones. Professor
Oh
Nick
yeah.
Jones was retired. Nick Jones had just been appointed after being working in London with Ian Mackay. And he started something called endoscopic sinus surgery that they've never heard of in Nottingham. And he was doing that. And
What year is this? What year
that
is
would
it?
be 1992.
92.
Yeah.
So
So,
before 92, we're saying no sinus surgery, people
yeah,
literally just drilling holes into the
exactly.
sinus
Yeah, there was
wall,
nobody.
hoping
Yeah,
for the best.
that's it.
Blind, not blindly, but near blindly, right? Just by
Yeah.
feel.
And it didn't work that well. So
No,
that's why
unsurprisingly. Yeah.
it was notoriously, had bad reputation. I'm going to have a sinus operation. It's not going to work. It was like this.
Yeah.
So then he was holding the endoscope and we look and we see all these things. That was fascinating. For me, that was like, this is the best thing ever. And that's why I liked rhinology then. So obviously I hadn't done it. I hadn't been able to do this. So I haven't touched it. So I still don't know until I was a registrar. Then I was taught to do it, which is only a couple of years later anyway. When I did it, I thought, oh, my skill is very good in this. I love it. So that was how I liked rhinology. So it was a developing specialty. It was a big revolution in it. Everything's like this, catches up slowly. So although it started in late 80s, but by the time other consultants learn it and catches up in UK in different regions, it takes ages. So there was a lot of hospitals still not doing this endoscopic sinus surgery until mid 90s, across the UK. Because Ian Mackay was the leader and he was in London. He taught a lot of people in London. So in London, it was different then.
Yeah.
But then across the area, and Nick Jones moved from London to Nottingham. So like I remember when I went to Liverpool later on as a locum, nobody was doing it. And that was
Which is
94.
unbelievable if you think about it now. I mean, it's probably one of the commonest operations we do,
Exactly.
endoscopic sinus surgery of all different ones. You can get very simple, straightforward ones, and you can get immensely complex ones
Yeah.
that actually go into skull-based surgery, right? And
Yeah.
everything in between. So there's a huge
Yeah.
variety. It's probably one of the commonest, other than tonsils and grommets
Yeah.
and things like that. It's probably
So some statistics, a few years ago, 20,000 sinus operations done in the UK a year. So that is a lot. Yeah. So that was some older statistics, much more now probably.
yeah,
But yeah, it
very,
is
very
because
common.
sinusitis is common.
Yeah.
Yeah.
And the difficulty with sinus operations is that you've got to have a brain that's very good at 3 dimensions because
Yeah.
you're looking on a screen. So for people who don't know, there is a telescope which you can look down with your eyes, and some people did do that, particularly initially. But now it's with a
That's right.
camera that's attached to a stack with a monitor. So you're looking at the monitor that projects the image seen through the
Yeah.
endoscope. So it's 2
It's
dimensional
magnified.
there. Yeah, massively magnified. And then, of course, you've got the CT scan of the sinuses, right? Which essentially is like cuts
Yeah.
through the face. And so
To
you've got to
detail.
put together what you see on the scan with what you see on the screen and then make it into a 3-dimensional
Yeah.
hole in your head, right?
Exactly. So not everybody can be good at it.
Yeah.
Although, you could teach most ENT surgeons to do it. That's why people tend to like certain areas. That's why you find maybe your mental ability or something more suitable to certain areas. So for me, maybe it was that. There was some time ago, people said people who are good in computer games are good in sinus surgery.
Yeah, I can
But
see that.
maybe it is true. We haven't proven that. But we need to get some
We can
people
do
who
a
are really
study,
good.
Hesham. We can do a study on,
You could do a
I don't know,
research study.
Roblox or something,
Yeah.
whatever it is. Yeah.
Yeah. So so it's eye-hand coordination, between, because you look it straight, you're not looking down to the patient, you look at the screen and
Yes.
operating like this. So eye-hand coordination and mental building a 3D image of what
You're
you're doing.
actually, you're not actually looking at the patient, are you? I mean, you might do when you're grabbing an instrument to pop it inside
Just
the
when you're
nose,
grabbing an
but other
instrument,
than,
but
yeah, but other
otherwise
than
you're
that,
looking at the screen,
yeah,
which is straight on
yeah.
from you
But
like that.
that discipline of rhinology, so
Yeah,
sinuses, is, as I say, goes from very simple, but goes all the way to the skull base, right?
yeah,
And it's the bit that anybody who's in rhinology, and I suppose I'd include myself in that, finds that the most exciting in some ways.
yeah,
But there's only so many, anterior skull base surgeons we need in the UK, right? But that's the
yeah,
bit that I think people very often. That's also the scary bit, right? It's one of the things we consent people. One of the
exactly.
dangers that we say
Yeah,
to people who undergo sinus surgery is say, look, the bone between your sinus and the brain can crack when we do
yeah,
this operation unintentionally. We can fix it, of course, but
yeah,
that's what happened.
exactly.
What was your experience in that jump from, just, staying in our lane and staying in the nose to then ENT surgeons going, you know what, this is actually a pathway to the brain. And of course we work, in certain units to do this closely with
Yeah,
neurosurgeons, right? How
yeah,
can you recall your path into going,
yeah,
actually, I'm going to go beyond the sinus and I'm actually going to use this as an approach to the brain?
yeah. So uh, Ian Mackay was already repairing CSF leaks, which is when there is a crack in the bone above the sinuses and the fluid is
About the leak
leaking.
from around the brain, right? Is
Yeah.
the brain
And
fluid.
patients were referred to him because he did it with endoscope. Uh, have it either accident that caused that, or maybe an operation caused this, or some people have it spontaneously, which is a bit of an unusual, rare condition. So he was repairing this already, which I learned from him. But I saw the research that was coming, especially from a group in the USA. They were doing what we call joint surgery. They work with a neurosurgeon at the same time, and they openly take the pituitaries out, for example, like tumors of the pituitary gland up here, or even meningiomas, like other types of tumors. They were doing that, and they had a big experience. I went there, I did the course, and I thought we have to do that. Nobody's doing this joint surgery in the UK yet. Although some people did the pituitaries in the
Mhm.
UK then, but that was it. Nobody did anything more than that. And because you can access, I mean, like the ancient Egyptians did that, the mummification, they went through the nose anyway. The brain is
They did, didn't they?
accessible.
That's how they took the brain out through,
Exactly.
yeah, they took it
Yeah.
out
So
through
I
the
thought,
nose.
yeah, I didn't think that because I'm Egyptian or anything like that. So I just thought, yeah,
You were
well,
destined. Yeah, you were
this is a
destined.
great, great area of surgery that we should be doing more in the UK. Yeah.
And
No,
what year is this, Hesham? What
that
year
was
is that?
2002. And I did I I did the course. I saw what they're doing. I saw we can expand that. So I talked to neurosurgeons who were a bit reluctant in the beginning. I kept convincing them, let me just show you. Let's just use the endoscope. We can show you that. And after, I think maybe it took me 6 months to a year to convince. So 2003, we did the first case, and then the neurosurgeon saw the light, and he was like
Literally,
jumping.
the endoscopic light.
It's endoscopic light. And I said, oh, that's great. I could see much more. I said, let's do more. And we started doing more. And then we got the group from Pittsburgh to visit us in Charing Cross Hospital to show how this is done, and invited everyone in the UK who have interest in rhinology, everyone I know anyway, advertise it everywhere. Anybody who wants to come and watch Skull Base, come and see that. And we had a lot of people who just did a day of teaching on this area. And many people tell me that was the launching of Skull Base in the UK then.
Yeah, that's
So
amazing.
yeah. So I presume like maybe other people had the idea, but I started it, I think, that then. But we knew it's happening, but we needed launch. And now there are lots of units that are doing this joint skull base surgery, which is great.
Yeah.
So our
But
unit
I think it's
continues.
interesting. It's very altruistic and charitable of you to say, look, we now know how to do it. Let's share that knowledge, because sometimes they can be sort of people who want to keep
Yeah,
it, right. But I think that spirit of sharing is how
yeah. I mean, you think,
expertise gets passed on.
like I know exactly what you're saying, Nora, because yeah, it's true. But I think like our time as surgeon is a certain time, okay, you can prove yourself, you'll be good and all this, but you really, it's all for the patient in the end. So we have to spread the knowledge. Everybody has to know it. You can't just keep your knowledge for yourself because you are the only one who want to do it. Everybody has to learn it, because then you get access to the patients. And I think and I think a lot of doctors feel the same, to be honest. These guys from Pittsburgh were like that too. They came, they were so generous with us and showed us everything. It was just great. And I think now we have very good units in the UK that do that.
Yeah.
Uh, like it's good. I want it to be more, but but it is good now.
It is, and it
Yeah.
is specialized. I mean, I think that's a very good time to sort of start talking about the patients, because I think the evolution of rhinology, endoscopic sinus surgery. We'll come to facial plastics in a second, but certainly sort of the advances in sinus treatments, medical treatment, by the way, as well, not just surgical, but surgical treatments of sinus surgery, skull base, etc. I mean, the benefit to the patient is immense.
Yeah.
We've gone from having something that was not treated very well at all to
Yeah.
now, so I think, so how do you feel, how do you think that the evolution of this surgery has benefited patients? What's in it
Yeah.
for the reason why we're here, which is essentially to improve patients'
Yeah.
life, right?
Yeah. So the great difference between doing things with endoscope and doing things with cuts and incisions is it's more targeted, but also quicker recovery because you're not creating big wounds. So, like in the past, like for example, the surgery that we often do with the neurosurgeons, moving a meningioma, they had to create what are called craniotomies. So they actually had to drill through the skull and go through that route and then find where the tumor is, just mobilize or a lot of work in a lot of tissue that can get swollen and damaged, so that the patient take much longer to recover and the complication rate is much higher. I mean, like we call brain edema, hemorrhages, and so on, much higher with open surgery. So that closed surgery shorten the patient's stay for the hospital, has less complication, quicker recovery, and probably ultimately better result from tumor because you could see exactly where you're doing closer with the cameras and endoscope. So
Everything's
that is a great advantage for the patient. And that's why this surgery has taken over in a lot of areas. So obviously it doesn't take everything from a neurosurgeon because a lot of other surgeries that neurosurgeons have to do by using different techniques anyway. But there are certain areas of the skull, which is that the areas are close to the nose. They can always access through the nose, smaller incisions from inside, and you remove whatever tumor is there and so on. So
Mm.
that's the advantage. It's a big,
I mean,
big, big
you
thing.
go from weeks recovery to days recovery, right? I mean, that's
Yeah.
the difference.
Yeah. From weeks or even months to days or weeks on. Yeah, exactly.
Yeah,
Big, big difference.
yeah.
Yeah.
Which is an unbelievable advancement of modern surgery. I mean, if you think that this, what we're talking about, is less than 20 years old or just over
Yeah.
20 years old, that's
Yeah.
quite remarkable. And this obviously happened,
Yeah.
through you and and by you. Um, let's go on to facial plastics, because in some ways that's quite a different thing, right?
Yeah.
And very often people are either on the sinus surgery side of things or on the facial side. And by the way, the facial
Yeah.
plastic side, that's an area we share with plastic surgeons, right? And maxillofacial surgeons. So it's not
Exactly.
just the remit of ENT surgeons. So sometimes when people go, well, who does the best, rhinoplasties, nose jobs? And you think,
Yeah.
well, whoever does the most, actually.
Yeah.
I might always say to them, actually, somebody who knows the inside of the nose is always very helpful, because you almost have to build it
Exactly.
from the bottom up. But yeah, so how did that piece come, the facial plastic side of things?
So that was also happened in because my mentors did both. So in the UK, it'd been traditionally like this at the time anyway, that a lot of the surgeons who did the sinus or inside also did the outside. Yeah, that's in contrast to the United States, for example, where they are different specialties. The ones who do sinus completely separate from the ones who do the facial plastics, rhinoplasties, facelift, and so on. But in the UK, it's been like that traditionally at that time. So when I worked in Scotland in Dundee, so one of the bosses, he was doing a lot of rhinoplasties. He learned it from one of the leaders in Canada. So that exposed me to that. And I really liked that so a lot. So I learned that a lot from him then. But then again, when I came to London and I worked with Ian Mackay was one of the leading, maybe two, of rhinoplasty in the UK, him and Tony Bull. And I just loved what he was doing because we do 50% sinus, 50% rhinoplasties. So I learned a lot from him as well. And when I worked with Valerie Lund does sinuses, and I'd already applied to do a fellowship post-training in the States because I believed in that type of really intense specialization in sinus surgery. And she said to me, why do you want to do that? You've done enough sinus with me and Ian Mackay. You should go and do facial plastics. I said, but I just write rhinoplasty. I said, no, but you should learn the whole face because it's useful. I said, okay.
Good advice.
Yeah. So perfect advice. So she canceled the fellowship for me. She called her friend who was going to be my boss in Johns Hopkins and was fine and helped me to do the fellowship of the European Academy of Facial Plastic in Amsterdam, part in Beverly Hills as well, actually. So I basically learned the whole face then and more rhinoplasty. So that's how. So it was working in parallel. And I started working when I started working with parallel with Ian Mackay, who only retired a year after I started. He's already been doing these. So when he left, we already have a waiting list of patients for sinuses and a lot of septorrhinos, like traumas and so on, because of NHS. And I started doing them both, and I've always done hundreds of each every year since then. So you build your practice in parallel. The one thing that you realize at some stage, after a few years, I realized it's impossible for me to do skull base, rhinoplasty, and sinus surgery at the same time. So I decreased the skull base a little bit. So I don't do the joint surgery. I stopped doing the joint surgery with the neurosurgeons because my colleagues are doing it now. But I do the skull base things that are suitable for me to do by myself.
Yeah.
So
So there's a little bit of, succession planning, because as you say, these things all evolve, right? And you can't be at the forefront of every single thing for decades and decades. And it's absolutely right as a team building, which I suppose is a really good way of saying, is there any, do you think there's misunderstandings out, and particularly now in the sort of social media world, there's so many things, particularly about facial plastics. Is there anything are there any sort of misunderstandings or sort of questions that people come to you with that you have to go, actually, it isn't this way, sort of they're either misunderstandings or something that social media's talked about, that you have to go, actually, we need to correct that, whether it's about fillers or how hard or easy nose jobs are, or, what to do for, sinus infections. Are there sort of common things that come up where you feel actually social media hasn't been great in telling people about it?
Yeah, definitely. I mean, there are things that have been useful from social media. Like if you look at, there's a lot of websites like online. I mean, I'm talking about the internet from big institutions like the Mayo Clinic or Cleveland Clinic and so on, and in the UK as well, that explains everything to the patient. And our ENT UK has so much stuff. So these are really good for patients to get information. But for facial plastic and cosmetic surgery, it's completely opposite sometimes, because there's nothing like that in a big institutions doing this. The information that patients get are a lot from Instagram, TikTok, and stuff like this, and some online patients or surgeons who really want to advertise themselves more than giving. That's my feeling anyway. I could be wrong sometimes, but maybe it's something. But I haven't seen it. But what I've seen is a lot of young people get really influenced by social media, and there's a lot of uh, doctors who are putting images a lot, which represent some unusual like shapes of noses and so on, and the kids believe that this is what should be like. It's unnatural looking noses that you call it the Disney noses and so on.
Yes.
It's scooped here and so on. So young people look at these things a lot, and they look at the fillers and looking at this. They think they want to have that. So you find so many young people who want to have fillers, for example, which it's not right in that young age. You find a lot of young people have rhinoplasty. Many more young people want to have rhinoplasty nowadays because they get influenced. They think they
Before, you think?
yeah, much more than before. And I'll tell you an example. A patient, like some of the patients come and think, one of two patients told me, the ones who have more followers in Instagram are the best, which is completely, completely obviously unbalanced. Because how do you judge a doctor by followers or by peer judgment or academic abilities and so on. And there is a paper published, and actually we're going to publish that paper on social media soon. There was something published that said when you Google some doctors nowadays, even Google puts the doctors on top who have more social media presence than their academic abilities or qualifications and so on. So that it's not very good for the patients.
No.
And if you saw the news 2 days ago, Australia decided not to allow anybody below 16 to have. Australia's been a leading, by the way. It's not only that last year, they completely changed the rules for doctors, social media posts and so on. The doctors who put pictures of patients, they have to have so much consent and so much proof that this is not being manipulated and so on is really, really good. Like, so to make sure that patients are not deceived and so on.
Yeah.
So that was done last year. UK has some system going on, but nothing yet. Yeah.
Yes.
So social media is good, but needs to be controlled a bit better because
Yeah.
especially in facial plastic, it can be really deceiving.
And it's
So
very easy to manipulate images. I mean, to the point
yeah,
where it is impossible to tell whether an image has been, I mean, the
yeah,
sort of the face morphing has been has been around rather for some time.
yeah,
Most facial plastic surgeons actually didn't use them exactly because they felt it was
yeah,
giving, because it's not that you can do anything and everything with any nose, right?
yeah.
There's only a
No.
certain
There's
amount that,
lots of limits. Yeah, yeah,
yeah, there are limits to.
yeah.
It's not.
I mean, like,
It's not plasticine.
so I use the facial, the software manipulation for 20 something years anyway, but I tell the patient this is just software. It's just to give you an idea that how we can try to change this. But it doesn't mean it's going to look like this exactly because that's just
Yes.
but you look, I mean, like I gave a lecture in the European Academy. It's called the Joseph Lecture last year. And I talked about particularly this. I showed pictures in the internet that are impossible to be not my, they are manipulated because the
Mm.
person looks like a different person, even the angles, everything. Yeah. So, and there's a lot of them in the social media, but y-
But the
young
more
people
you
don't
see, the
know.
more
Yeah.
difficult it will be. It'll be more normalized,
Yeah.
and as younger people come through, they won't have those antennae that know what is and isn't possible. So
They
it's
wouldn't know.
really,
They wouldn't
yeah,
know. Yeah.
it's setting
So,
unrealistic expectations of beauty as well.
exactly. So I hope there's some more control that comes in general in the UK as well. But it is hard to control it completely. And now with AI coming as movies as well, sometimes you look, is that real or is it AI as well? All these things. So we are an area of, speculation. We don't know what's going to happen, but something has to be done. At least Australia is doing something, which is good. I
Yes.
respect that. I hope we can have something similar.
Yeah,
Yeah,
and there's one bit is regulation, and the other bit is actually sort of providing guidance. You're
yeah,
mentioning it in
teaching.
the UK, so it's
Yes,
maybe
yeah,
something, to say, look, providing guidance, then you mustn't, if you have put on pictures that look manipulated, then you have to declare that. So
yeah,
very clear. A little bit like, when you had social media influencers, they had to declare if they were being paid for an ad. So
yeah,
they don't just love those shoes, they're being
yeah,
paid to show
yeah.
they love those
Yeah,
shoes, right?
yeah. Something simple like that. Like there's something in the UK. I that was like announced last year or beginning of last year that they're gonna use a software to detect which pictures are manipulated.
Mm.
This is gonna work or not. I don't know. So every ad by somebody that's showing some plastic procedure, the supposed to be that AI software can detect which one has been played with, changed, or manipulated, and so on.
I mean, it's the new frontier, isn't it? I think
Yeah,
it's the new
yeah,
era. I mean, it'd be interesting to see how the AI will affect things like, because we've got the sinus surgery mapping, for example.
yeah,
The brain lab allows you to look on the screen and in 3D reconstructs the sinus
yeah.
images. Hopefully that can get a bit better because that hardware is quite clunky, right?
It will
And
improve.
very, very
Yeah,
expensive.
yeah.
So,
So actually,
uh,
AI is amazing. I actually do a lot of research with AI group in the Imperial College.
oh yeah,
So we've already got the AI to teach the AI to read the CT scans of the sinuses.
amazing.
Certain areas, not all of it. Yeah. So
Yeah,
it's like a beginning. So we've done some research in that. But ultimately, the human being has to look and make sure because who's responsible for the mistakes of the AI? Yeah, so you have to check it, but it will just make it more efficient and quicker. So that's one thing, and we're now getting the AI to read the inside of the nose, the measurements of the breathing and the size of the nasal cavity and all that. So I think will help us a lot
yeah,
in various things, but we can't just completely depend on AI. I think the future also because always going to be somebody who's going to be responsible for this. So if AI
100%.
is making a mistake, it's a big, big thing, and you can't
Yeah, and who
just
carried
yeah,
that?
yeah,
I mean, and on that note, what do you think? So you started your career in ENT in, let's call it, early 90s. Is
yeah,
that fair?
yeah. Early 90s, yeah, exactly.
Early 90s, yes. So 35 years in
Yeah,
ENT. what do you think? This is a really hard question because I think it's very difficult to predict where we are. But where do you think ENT will be in 35 years? So that will, that will take us to,
Yeah,
2060, which is
it's,
quite obviously.
yeah, it's difficult to predict, but I can predict a few things actually.
Okay.
I
Let me.
predict, yeah, that a lot of the sinus problems are going to be treated with medicines, not with surgery.
Okay.
Because, for example, like now we have what we call the biologics that you inject them, they target the exact inflammation which causes polyps, and the polyps can disappear, for example. So we do a lot of sinus surgery for polyps. Actually, two-thirds of the endoscopic sinus surgery in the UK done for polyps. The other one-third is of sinus infections. Yeah, so so imagine these two-thirds can go away at some stage. So a
Mm.
lot of these sinus surgeries may just be gone or just less. So I think that will happen. 35 years, probably definitely. That a lot of these conditions are treated with medicines or injections and so on. So that's one area. I think there'll be some robots. Robotic surgery has advanced a lot in other areas outside ENT, outside the nose and sinus and so on, because the robots, they're a bit more bulky, so you can use them in the abdomen and so on, and the neck and so on. And they have improved a lot of areas. We need to create, which the research is going on. There will be robots that are small enough to go through the nose to remove the tumors in the brain tumors and so on. I think that will happen. So I
Mm.
think maybe there will be something like that. It's not going to be done by AI. I think the surgeon still has to do it.
Yeah.
Yeah,
And actually, just on that note, when people think about robotic surgery, some people think that it's little robots that are doing it, and it isn't. It's
no,
just that it's a human controlling it,
exactly. It's a
but the human
console.
sitting on the side. Yeah. So go
Yeah.
ahead. Yeah.
So the human is holding the instruments in a console as here, and that's connected to arms. The arms just mimic exactly precisely the human movements. So when they're stitching, it moves like the stitching. When they're holding a forceps, it moves like that. And it's very precise. It transfers the movement. Interestingly, it doesn't transfer tremors.
Yeah.
Yeah. So it just cancels the tremor. So any surgeon, everybody has a bit of tremor anyway, but any tremor just gone. So it's such a stable equipment. It's really amazing.
There's still a
But
human doing the operation. It's just
human
that
doing it.
it's
Yeah.
yeah. It's
So it's not a robot.
yeah.
So for a robot to operate on a human being, I think that will take a long time. It may happen, but I think that will take a very long time. So
That's a
it's
very long.
nothing like this. I don't think there's any EV technology coming that way anyway. So I think that's what the area of my area that would be like the robotic surgery. There'll be a lot of areas that are not going to be treated with surgery anymore, like sinus problems. Cosmetic surgery may probably could continue the same actually, unless they change the genetics of everybody.
Yeah.
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 So
And then
yeah,
the AI obviously is a part, right? I mean,
AI
AI
will.
now
Yeah,
in sort of dictations,
yeah.
it's
So
very good at
AI
isn't it?
exactly. Yeah. So a lot of the things that will save a lot of time when you're seeing patients talking to them, AI is listening, which we already use now. AI is listening and writing everything you said. And so all the reports will be written by that, which is available. It's nothing that would be like everybody will use that, I think. So hopefully we'll save our time and not using the computer like we are now. It will be done for us. And AI will help us to read the CT scans, the X-rays, the pathology, any specimen that we take from a patient, the AI will help us read it. It will be quicker and efficient. Uh, Run a lot of the tasks that we don't want to do that are not dangerous or anything like that are just
Mhm.
like managerial things. So I
Yes.
think this will be a commonplace. Yeah.
Yeah. And so as we sort of wrap up, I mean, you've gone I mean, I think this is an amazing journey and the fact that you're, I won't give away how old you are, but essentially, you're very, very senior surgeon, Prophet Imperial, and you continue giving back. I don't think you'll ever stop teaching. I don't think you'll ever stop research. I don't think you'll ever stop writing. And I think you've got this sort of quenchable thirst and curiosity that means you're always doing something and looking for the next improvement. How do you want people to remember you? Because what would you like your legacy be? When you actually hang up your loops for a final time, what do you want people to remember you as? What do you want your legacy to be?
I think your legacies comes from the people you taught, basically. So
Mm.
I think I want people to remember me. I just said that I I wanted to teach. I wanted to improve all the time. I actually we're talking about this yesterday. I created a logo for the fellows, and I was thinking, what's my motto? So I said, always learning, forever humble. Yeah. So I put that in the back. So I want people to remember me that I want that. That's an important thing, and just want to develop. And I think curiosity you're talking about is really important. Always be curious and just keep improving. Yeah. So I want people to remember me that I was that. I just wanted to get better all the time, but I have to stay humble because that's how you learn. You always want to be better. I think that's it.
Yeah.
Yeah.
That, that really is amazing. I mean, I think that, that endless ability to learn, and that constant I think humility, because it's very inspiring to hear that from someone like yourself, who essentially is at the top of it. There's not many people that can teach you anything, but you're teaching yourself. You're looking. So thank you, Hesham, and thank you personally, because you certainly are that teacher and mentor to me amongst many others. So
Thank you. It's been great.
thank you.